Thank you so much. Well, my name is Tiago Torres. So yes, Curtin, you said it quite well. I'm a dermatologist working in University of Porto, and the topic of my presentation is treatment options for palmoplantar and nail psoriasis. So my disclosures. Well, and when we talk about palmoplantar and nail psoriasis, we talk about two difficult to treat locations that also include the scalp, the face, and the genitals. But in fact, most of the cases are not really more difficult to treat. They are indeed very impactful areas, but not really more difficult to treat areas. The problem is that they are usually undertreated. So we are treating most of these cases, palmoplantar psoriasis and also nail psoriasis, with topical agents, and systemic treatments are being starting too late. So maybe some cases of palmoplantar psoriasis, particularly those with pustules, or very severe nail psoriasis may be more difficult to treat, but most of the cases respond quite well to biologic therapies. Okay, so what does difficult to treat locations mean? So we're talking about psoriasis, in this case, nails or palmoplantar psoriasis that are localized in certain areas and that require special considerations for effective treatment. So they may be localized or associated with plaque psoriasis in other areas. So they are usually prevalent. We see that nail psoriasis, up to 30% of the patients may have nail psoriasis. In the disease course, up to 80% may have involvement of the nails in some part of their disease course. And for palmoplantar psoriasis, 16%, up to 16% of the patients may have palmoplantar psoriasis. But if the psoriasis is severe, up to 80% may have palmoplantar involvement. So this involvement is frequent. It is associated with high physical and psychosocial burden and decreased quality of life. They are often underdiagnosed, and this is a problem because sometimes physicians frequently underestimate the burden and severity of these types of psoriasis. And for this reason, they are usually undertreated, as I said before, being treated with topical agents instead of systemic agents. And often they are resistant or prone to side effects to topical therapies and UV therapy. So the quality of life is lower among patients with palmoplantar psoriasis and nail psoriasis due to pain, impaired mobility, due to the stigmatization, because very visible disease with anxiety and depression. So clearly, the quality of life of patients that have psoriasis plus nail psoriasis or palmoplantar psoriasis is for sure, the quality of life is lower than when there is no involvement of difficult to treat areas or highly impactful areas like nail psoriasis and palmoplantar psoriasis. So it's when nails and palms and soles are involved with psoriasis, there's a significant physical, social, and functional impairment. In palmoplantar psoriasis, the high visibility of the lesions leads to social embarrassment, stigmatization, so decreasing the quality of life, and also compromising the ability to work and the mobility. So it has a high impact on the patient. Regarding nails, there's a substantial functional impairment. There's pain in the nails, in the fingers, there's discomfort, and of course, a high psychological stress due to the visibility of the lesion. So for sure, decreasing the quality of life and the productivity of these patients. One of the problems that also leads to underestimation of the severity of the disease by physicians and then leading to undertreatment is not measuring the severity well using the correct specific tools for measuring the severity of nail psoriasis or palmoplantar psoriasis, because in fact the commonly used scoring systems underestimate the severity. Of course, there are several tools, several scoring systems. Some may be a little bit more difficult to use every day. But for example, physician global assessment of the fingernails, of the palms, of the soles are easy to use. And our goal should be to clear or almost clear nail psoriasis or palmoplantar psoriasis. And in fact, this should be our treatment goal when treating nail psoriasis and palmoplantar psoriasis. So it should be similar our goals when we are treating plaque psoriasis. So clearance or almost clearance of the lesions should be our goal. It's the only way to reduce the disease severity and improve quality of life, so to patients to be able to have again the mobility, the self-care, engaging in the usual activities, and of course, reducing the pain, the discomfort, the anxiety, and the depression that sometimes is associated with these types of psoriasis. Of course, it's not only important the short-term efficacy, we need long-term control of the disease. So we should always think about the safety profile of the drugs. And we know that when we're talking about systemic therapies, the target therapies allow us to have long-term control, while the conventional systemic therapies in the long term, there are always problems with the safety or with side effects. One of the problems when thinking about managing nail psoriasis or palmoplantar psoriasis is the fact that there is a lack of standardized treatment guidelines because we don't have a lot of evidence-based data. Okay, so how to manage nail and palmoplantar psoriasis? Well, topicals and phototherapy are usually difficult to use or have low efficacy. So systemic therapy should be the first-line therapy for nail psoriasis and palmoplantar psoriasis. And we can expect a similar efficacy and safety profile from the conventional systemics and biologic therapies, well, similar to what we have seen in plaque-type psoriasis. Maybe palmoplantar psoriasis, particularly with pustules, we may see a decreased efficacy of these drugs. Okay, so when looking at conventional systemics and biologics, we have more evidence for biologic therapies in palmoplantar psoriasis and nail psoriasis. We have some specific randomized clinical trials for the treatment of these areas, or sub-analysis from randomized clinical trials in plaque-type psoriasis. We have limited evidence with conventionals. Regarding efficacy, of course, we can expect higher clearance rates, a faster onset of action with biologics when compared with conventionals. And of course, as I said before, safety profile is clearly different. We can use in long-term advanced target therapies, while for conventionals, the safety profiles may limit the long-term use, and we need to control these patients in the long term. Okay, let's start with nail psoriasis. Well, we know there's an association between nail psoriasis and psoriatic arthritis. There's a close anatomical relationship between the nail and the joint. So patients with nail psoriasis, particularly severe nail psoriasis, are more likely to develop psoriatic arthritis. So we should also think about this when managing these patients. Well, we can expect the response to be a little bit slower than with cutaneous psoriasis, but so we should expect some the effect of the treatment between 3 and 6 months. Well, there's some limited data with conventional systemic therapy showing some efficacy with methotrexate or cyclosporine, but we always have the difficulty or the limitation of long-term management due to the toxicities associated with these agents. Okay, a recent systematic review has been recently published, evaluating the clinical trials of drugs used in nail psoriasis, and it shows, so data from the head-to-head trials show the greater efficacy of ixekizumab over adalimumab and ustekinumab, as we're going to see, as well as brodalumab over ustekinumab. But the data from other agents, including IL-23 inhibitors, show also promising outcomes in the treatment of nail psoriasis. Now, the idea is not to enter in detail, so I'm just showing some data from the clinical trials. We can see for ixekizumab, it was compared with ustekinumab, showing clearly higher efficacy. So around 70% of the patients achieving a clear nail psoriasis. Brodalumab was also compared with ustekinumab, and again for an APSI 0, so clearance of nail psoriasis. Brodalumab outperforming ustekinumab, around 60% of the patients with brodalumab achieving a clear nail psoriasis versus 40% with ustekinumab at 1 year, and also secukinumab showing efficacy in the treatment of nail psoriasis. How about IL-23 inhibitors? Guselkumab was compared with adalimumab in the Voyage 1, and looking at the patients with fingernail psoriasis, and again looking to a clear or almost clear fingernail psoriasis, it was very similar at week 24, about 60% of the patients achieving clear or almost clear. The adalimumab was a little bit more faster at week 16, but at week 24, very similar rates of clear or almost clear fingernail psoriasis. And for risankizumab, also the sub-analysis of the patients with nail psoriasis showed a nice efficacy clearing nail psoriasis. Okay, moving on to palmoplantar psoriasis. And when talking about palmoplantar psoriasis, we need to talk about different phenotypes. So there's the non-pustular hyperkeratotic palmoplantar psoriasis. There's the pustular palmoplantar psoriasis, and then there's palmoplantar pustulosis. So starting with the non-pustular hyperkeratotic palmoplantar psoriasis, and also palmoplantar psoriasis with pustules. So we're talking about the presence of plaque psoriasis, so with erythema and scaling that are located in the palms and the soles that may be associated or not with plaque psoriasis in other parts of the body. In some cases, there may be some sterile postulation that appears in this plaque psoriasis localized to the hands and feet. Okay, and around 60% of the patients may have this kind of palmoplantar psoriasis. How about palmoplantar pustulosis? So this is a variant of pustular psoriasis. It probably is a separate entity from plaque psoriasis, although there are some shared molecular and genetic mechanisms. So in this case, we have pustules, mainly pustules in clear skin background, so localized in the palms and soles. It's more usually seen in females. It's strongly associated with smoking, and the prevalence is quite lower, or it's lower than what we see in non-pustular palmoplantar psoriasis. How about pathogenesis? Well, IL-17 appears to play a significant role in palmoplantar disease. Clearly, there's a strong expression of IL-17A in this type of psoriasis. When pustules are present, so pustular palmoplantar psoriasis or palmoplantar pustulosis, again, IL-17 signal appears to be very important, as well as IL-23 signaling. And very important is the fact of some evidence showing that in palmoplantar pustulosis, there's also the activation of other immune pathways, including Th2. And this may explain some of the data that I will present in a few slides. Okay, how about the management? Well, topical therapy is not usually effective. Phototherapy may have some efficacy in palmoplantar psoriasis, particularly non-pustular. And when looking at systemic therapies, they are usually a little bit less effective than in plaque-type psoriasis, particularly in pustular forms. So we can expect biologic therapies to be more effective than conventionals, and within biologics, TNFs to be a little bit less effective than IL-23 and IL-17 inhibitors. So this is a very recent systematic review and network meta-analysis evaluating small molecules, inhibitors, and biologics for palmoplantar psoriasis and palmoplantar pustulosis. So in this case, several agents were evaluated, and it was shown that it was shown that secukinumab and guselkumab appears to have the most favorable efficacy when treating palmoplantar psoriasis and palmoplantar pustulosis. But in fact, there are not a lot of clinical trials evaluating these agents, so sometimes it's difficult to do this kind of systematic reviews and network meta-analysis. So looking at the data from the Voyage study that compared guselkumab and adalimumab, and looking at those patients with palmoplantar psoriasis, non-pustular, so we can see that, and looking at the outcome of clear or almost clear palmoplantar psoriasis, guselkumab outperformed adalimumab. So around 80% of the patients with non-pustular palmoplantar psoriasis achieved a clear or almost clear, while around 60% with adalimumab. Well, looking at IL-17 inhibitors, and it's not head-to-head trials, so we can see for secukinumab, and again, a clear or almost clear palmoplantar psoriasis, around 60% achieving this outcome, and around 70%, 75% with ixekizumab, a clear or almost, in this case, clear palmoplantar psoriasis. Well, for small molecules, the primulase and the deucravacitinib, it appears a little bit less efficacy, but again, these are not head-to-head trials. And now look at palmoplantar pustulosis. So this was a recent systematic review we published evaluating randomized controlled trials for palmoplantar pustulosis. In fact, what was seen is it clear the efficacy of all the agents that were evaluated is lower than what we can expect when treating non-pustular palmoplantar psoriasis or plaque psoriasis. So looking at the precise trial that evaluated secukinumab for palmoplantar psoriasis with pustules, the response is clearly lower than we see when there is no pustules. And the same thing for guselkumab. We could expect, and this is nice data, we could expect for in palmoplantar pustulosis, and we know that IL-36 signaling is important in palmoplantar pustulosis, that the inhibitor of the IL-23 pathway, spesolimab, could be a good option. But the thing is, in 2 clinical trials, spesolimab did not achieve the primary endpoint. So in very severe patients, it showed a little bit more efficacy than compared with those with lower severity, but clearly it did not achieve the primary endpoint in the first clinical trial and also in the second clinical trial. So showing modest improvement in the efficacy endpoints of patients with palmoplantar pustulosis. So it appears not to be the answer in these patients. And this may be due to the fact that, as I said before, in palmoplantar pustulosis, other immune pathways may be also active, in this case Th2. So I bring this data from this is a small trial from the Manchester group with only 16 palmoplantar pustulosis cases, previously treated without benefit with several biologic therapies that were treated with the tofacitinib, so a JAK inhibitor, a pan-JAK inhibitor. And a very good response was seen with almost complete resolution in 10 of the cases in less than 1 month. And this may be due to the fact that with JAK inhibitors, we can inhibit the Th2 pathway, but also other pathways that are important in palmoplantar pustulosis. And there are several case series and case reports showing the effectiveness of JAK inhibitors in palmoplantar pustulosis, so maybe a good option when dealing with this type of patients. So, take-home messages: psoriasis is difficult to treat locations, particularly the nails and in the palms and soles are prevalent, are often underdiagnosed, and the burden is frequently underestimated and undertreated. So although affecting only a small percentage of the body surface area, it is associated with a high impact on the quality of life when compared with common plaque-type psoriasis. So there's a need to have a long-term clearance or almost clearance of the lesions to improve the quality of life of these patients. And the thing is, it's in most of the cases, these cases are being undertreated with topical therapy, with UV therapy, that is not as effective as we should be for this type of psoriasis. So systemic therapies, particularly biologic therapy, due to its long-term efficacy and safety profile, is probably the best option to treat psoriasis located in the nails and also in the palms and soles. And with this, I thank you your attention.
Thanks a lot, Tiago. I'll keep one single short question, so because we're running a bit out of time, and Christina has enough time to start her firework. Just one thing, you said that scalp psoriasis, perianal, and nail psoriasis are a predictor for PSA, psoriatic arthritis as well. Should we take that into consideration when choosing a therapy, so we cover PSA as well, or how do you see that?
Yes, I agree with you. From all those areas, I think I believe that we have strong evidence regarding nail psoriasis, and there's a rational, anatomical rationale to understand that. When you're talking about scalp or intergluteal, I know there's a study showing that probably is a risk factor, but it's more difficult to explain the association. But I completely agree with you when treating nail psoriasis, and that it's a risk factor for psoriatic arthritis. When thinking about the treatment, we should also think about the efficacy on psoriatic arthritis, and we know that some agents are more effective for psoriatic arthritis than others. Yeah, I agree with you.
Thank you very much.